Alrighty, I'm going to start with the acid controlling drugs. And so looking at these, we know that things that can affect the secretions within that GI system. So we talk about what is ulcer disease and erosions of the lining of the stomach. And we that kind of umbrella of peptic ulcer disease or PUD. And under the PUD, we can have duodenal ulcers or gastric ulcers, with duodenal being more prevalent, and causative factors, which I'll get into here in a minute. We said that with the duodenal, a lot of times food can help eliminate the symptoms they'll get with it, versus gastric, food will exacerbate the pain or the symptoms. The older adults, and keep in mind for really all the medications we talked to today, is that they are more prone to those adverse effects or side effects of sedation, dizziness, urinary retention, confusion. Okay. The parietal cells is really a main focus of cells in the stomach, and looking at the hydrochloric acid, again, secreted by the parietal cells, we know that there are certain factors that will stimulate the hydrochloric acid, and that is caffeine, chocolate, alcohol. The stomach acidity pH remains between 1 and 4. Okay. Other things that can aggravate the HCl is large fatty meals and emotional stress. One of the most causative factors of the ulcers, whether it's duodenal or gastric, is H. pylori. H. pylori, again, causative factor from that, a lot of times leans towards unsanitary food, soil, water. So we talked about stress related, so stress ulcers, really common in those really acute sick folks, like ICU patients. We're going to look at the different type of acid controlling drugs, antacids. The biggest thing I would tell you from there, again, is it neutralizes only, does not manipulate the production. So it's going to neutralize acid secretions. Okay. It will help to raise the gastric pH, but that's different than the manipulation of the production of the gastric acid, okay? So it will raise the pH. Higher pH means the less acid it is. Remember, again, over the counter, as far as capsules, powders, chewables, suspensions, and effervescents, that's slowest to a fastest absorption. So capsules is the slowest, effervescent is the quickest. So look at that. With antacids, we said that they can be used alone or they can be in combination. So looking first at the aluminum salts, those more readily cause constipation. They can be often used with a magnesium combo to counteract the constipation. And the aluminum salts are the ones that are more recommended for your kidney folks, because they can excrete the aluminum easier than they can the magnesium. And then a few examples of the aluminum ones you can see on this slide. Magnesium, flip side, can cause diarrhea, contraindicated or really dangerous with your kidney folks because they cannot secrete that extra mag. Some examples like milk of magnesia, Gaviscon. Calcium salts, these are going to go back to, think of the word calcium in those stones, so the Tums, calcium carbonate, so higher risk for constipation and kidney stones. Sometimes used or advertised as an extra, dietary supplementation. With your sodium bicarb, again, it has a quick onset, but it's very short-lived, and it's kind of more contraindicated, or you're watching that this use with the sodium in those renal patients and heart failure patients, and then also the bicarbonate. The mechanism for that one really works as a buffer against the acidity. Okay. The only other thing too with the adverse effects I would tell you is for the calcium carbonate, it can also produce gas and belching. So that is the one you're going to see the combo sometimes with the simethicone, which is an anti-flatulent. We know that absorption of other drugs, that antacid can reduce the ability of other drugs to be absorbed in the body. So time factor is certainly something to be very aware of. Looking again at any pre-existing conditions. So again, that heart failure, renal, GI obstruction, pregnancy. We did talk about how the medication should be administered 1 to 2 hours after an antacid because again of that absorbency that can be interfered with. We know that also the timing around enteric-coated medications is also warranted as it can disrupt the enteric-coated medication. If they're chewable tablets, make sure that they are chewed thoroughly. Liquids are well shaken. Plenty of water, at least 8 ounces of water. We do not use antacids for long-term self-medication because it can mask underlying diseases. And that in general, with any of these medications, if a patient's not getting symptomatic relief, they should follow back with their healthcare provider. We want to just continue to look for any kind of adverse effects. And we had mentioned that with calcium-containing products, those calcium salts, patients with long-term use can get that hyperacidity rebound. With H2 blockers, so these are going to block the histamine in the gut. These do manipulate the secretion of acid, so this reduces acid secretion. Looking at those meds that end in the TIDINE, cimetidine, famotidine, ranitidine, those are your H2 blockers, so reduce acid secretion. Okay. So again, we said that you need acid to order for digestion and breaking down medications, so it's very cautious to manipulate that environment with these medications. Okay, some of the things that we see the indication for an H2 blocker is GERD, again PUD, the erosive esophagitis, or as an additional therapy to control GI bleeding. Generally very well tolerated, but these for the older clients, again, you can see that central nervous system disorders or effects with confusion or disorientation. We know that smoking can definitely decrease the effectiveness of H2 blockers because it can reduce the mucosal blood flow. And again, we like to have this administered 1 to 2 hours prior to any antacids. Again, still looking for any other underlying health conditions. PPIs, so we know that PPIs will go in and shut down the proton pump of the parietal cells. This is where a large production of your HCl is produced. Some of those PPIs that will end in PRAZOLE, like omeprazole, pantoprazole, are your PPIs. Again, indications for why PPI will be used. It kind of overlaps with the H2, so the esophagitis, the GERD. The PPIs are really the ones you'll see more for the stress ulcers, prophylaxis, so those really acute ill patients. This is the medication too that will be in the combination therapy to treat H. pylori. And again, H. pylori is a bacteria that has to be treated with it's usually 2 antibiotics with a PPI in it. And then also PPIs are good for NSAID-induced ulcers. Again, pretty well tolerated. Long-term use can cause potential for osteoporosis, pneumonia, which we said that like lipid pneumonia, depletion of MAG. Again, looking at that, we are judiciously using it for people that are on any kind of blood thinners. We mentioned the diazepam, the seizure med of the Dilantin. With the capsules, again, we said we push meds in just to make sure that the tube does not clog up, so the capsules can be opened and put in applesauce or pudding or something. Miscellaneous drugs, we talked about the Carafate, and that's used for stress ulcers or PUD. It really goes to the base of that erosion or that ulcer and tries to kind of coat it to help with healing. Again, this is one of those time-sensitive medications where you want to give the Carafate or sucralfate really on its own, so it's not having to compete with other medications. Cytotec or misoprostol, again, we talked about this with NSAIDs. This is the medication that will be used to promote gastric mucosa health and from those ulcers that can form from the NSAID. So that one is usually a great one for people who's on long-term NSAIDs. Simethicone, again, is anti-flatulence to help break up those gas bubbles. And again, you can have simethicone on its own, or you might see it combined with your antacid. That is it.